for this session. So, Dr. Mukundan R is an associate consultant in the cornea and ocular surface department at Shankar Nethralaya, Chennai. He specializes in treating a wide range of corneal conditions with a research focus on corneal infections and ocular surface disorders. His surgical expertise includes corneal transplantation, cataract surgery, corneal trauma, and ocular surface procedures. Dr. Mugandan has also received several accolades throughout his academic career, including first place in Pondicherry University, third year MBBS exam, and 4 gold medals at Pondicherry Institute of Medical Sciences, and the title of Best Outgoing Student in 2009. Additionally, he was awarded the R.K. Bansal Travel Grant Award in 2021 from L.V. Prasad Eye Institute. So, thanks, Dr. Mugandan, for joining in. Let's see if we can have these slides, or else we'll go without this.
Sir,
Thank
are
you
my
so
slides
much,
visible?
Dr. for that kind introduction.
Yes. So Dr. Mugandan, this is off to you, and
Okay.
you can just take. So this is more like a discussion, and so that we can learn more how to go about, and with focus both on being as a resident and as a clinician to how to manage and how to go about. So Rohit, you can start, and please introduce yourself, and Dr. Mugandan, off to you.
Yeah. Thanks,
Have-
Dr. Anuj, for the introduction. Rohit, yeah, please go ahead, Rohit.
Yeah. Hello, everyone. Good evening. Dr.
Hello,
Rohit Sawan.
Rohit.
Yes. Are my slides visible, sir?
Yes, yes.
Okay. Hello, everyone. I'm Dr. Rohit Sawan. I'm from Pune. I'm currently a third year resident at JPM Rotary Eye Hospital in Cuttack, and I would like to thank you for this opportunity.
Hello.
Hello. Hello.
Yes, Rohit, go ahead. Yeah.
Sir, am I audible?
Yes, yes, you are audible.
Okay.
You can
So,
start.
yeah, a 50-year-old female comes to the outpatient with the chief complaints of diminution of vision and watering in the right eye since the last 15 to 20 days.
Rohit, your
Uh,
voice is hello.
Hello. Hello.
Hello.
Yeah.
Yeah. Your voice is breaking. Might be now you are not able to see the screen. Is my
Oh,
voice audible?
yes, sir. Sir, your voice is clearly audible.
Okay, okay. Then start the. Now we are not able to see the screen. Yeah. Start. Hello. Hello.
Yes, Rohit.
Dr. Anuj, is I'm only facing difficulty with Rohit connection, or it's weak on or it's my connection is weak. I'm
No,
not sure.
right now we are not Rohit. I think yeah, we can only see Rohit's slide.
That got stuck. We're not able to hear him.
Yeah. Let's see if we're maybe he'll join in from some other device.
No, might be in the meantime if the other residents who were connected. So, what is 50 female with complaints of diminution of vision?
Yeah, so we can just go discuss whatever we are seeing. Like
Yeah. Any resident, if Rohit can go to the clinical picture, can any resident describe the clinical picture based on the history? So he has given the history of 50-year female with the complaints of diminution of vision and watering in one eye, that right eye for the last 15 to 20 days, and there was no any past history, no other systemic history, and not on any medication. So can any resident take this question? Can describe the clinical picture? Might be whom I'm seeing. Madhuri. Madhuri, can you take this question? Can you describe the clinical picture? Or if Rohit can go to the next slide where the picture is little big enough. Or Narmada Devi, or Madhuri or Narmada Devi. Or anyone.
Rohini, you would like to take?
Sir, actually, I have recently joined. I am not able to see the slide.
Okay, okay. I think Rohit has joined again. Let's see if
He can, yeah.
Rohit?
Yes, sir.
Yeah.
Sir,
So
was I audible all this time?
no.
Oh, actually, I had presented the entire case. Sir, should I start once again?
Yeah, please start.
Definitely.
Sir, were my slides visible at least?
Yeah, slides
No.
were. Only the first slide was visible.
Only the first slide was visible. Okay, sir. Just give me one more minute.
Or else you can the slide which you have shared, it's the same one. Could I?
Yes, sir. Yes,
Okay.
sir. Absolutely the same one. Yeah.
Okay. So just see if you can share them, or else I'll share from here.
So actually, I'm trying this. I think there seems to be
Okay.
some problem on my end.
ठीक है. You can describe the case. I'll meanwhile share the slide.
Okay, sir. Okay, sir.
You can just.
Yeah.
Rohit?
Yes, sir. Should I start?
Yeah, please, Rohit.
Yeah.
Yeah.
A 50-year-old female comes to the outpatient department.
Rohit, we are not able to see the slide. I think, yeah, one. Okay. Yeah.
Yes, sir.
Fine. Correct. Yeah. Correct. Yeah.
Yeah. Thank you so much for the patience, sir. So, a 50-year-old female comes with the chief complaints of diminution of vision and watering in the right eye since the last 15 to 20 days. Upon inquiring further, there were no similar episodes in the past.
I
There
think
is no
Rohit, you
significant
did the
systemic
stop
history.
share accidentally. I think again the slides gone.
Yeah.
So can you share the slides and then go to the straight away the clinical picture slide might be.
Okay. Sir, Anuj sir is sharing the slides while
Okay,
I'm.
fine.
I'll just. Yeah, you can describe the history till then.
Yes, sir. So the patient is a 50-year-old female patient, sir. She came to our outpatient department with the chief complaints of diminution of vision in the right eye and watering since the last 15 to 20 days. Upon inquiring further, she said that she didn't have any similar episodes in the past. She has no significant systemic history, and there is no history of taking any medications. We inquired further for some negative history. There was no history of trauma. There is no history of any skin rashes, especially around the ocular adnexal area. There is no history of joint pain or any systemic inflammatory symptoms. There are no recurrent oral or genital ulcers. There is no history of previous any ocular surgery. And there is also no history of fluctuating vision or halos.
Rohit, with the history, in the first slide, so based on the history, what will be your differentials? Then see, because next only you'll be going to negative history, na? So
Yes, sir.
50-year female complains of diminution of vision in one night for the 15-20 days. That means acute episode.
Yes, sir.
It's an acute, not a chronic thing. So what all differentials you will think of?
So the most common, if a patient is coming with DOV and watering, it can be due to conjunctivitis as well, keratoconjunctivitis. It can
Yeah.
be a corneal foreign body. It can be a corneal ulcer, which is causing DOB and watering in the right
So
eye.
the patient didn't complain of redness or pain, is it?
No, sir. No complaints of redness and
Because
pain.
in infection etiology, mostly there'll be more of redness, pain, like for acute redness, pain, watering. So here this patient has
Yes, sir.
complained of mainly diminution of vision and watering. Okay, so
Yes,
what
sir.
all you will think of differentials? Yeah. There was no pain. Patient didn't complain of pain.
No pain, sir.
Okay. And you correctly mentioned there was no history of trauma. You mentioned for any acute episode, we always ask a trauma history. Then infection history might be a redness, discharge, pain. Those also are more towards infection. Like can be any ulcer, microbial keratitis. We have to rule out or conjunctivitis. Then systemic history. Why did you ask for systemic history? Like
Uh,
what? No significant you have mentioned. So what is systemic history you asked for?
Sir, I wanted to actually inquire about systemic symptoms like whether she has any issue of joint pain,
No.
whether
Mainly, so that you have given in the next slide as a negative history. But systemic history, usually what you will ask, what you
sir,
mean.
I want sir if the patient is a known diabetic or if the patient
Yeah,
is in an
correct.
immunocompromised state.
Correct. So diabetes, hypertension, and immunocompromised state, or patient
Yes,
with
sir.
a frequent allergy. So
Yes,
those
sir.
are important risk factors, not pertaining for this case alone. Any case. Then medications also okay. Some medications can cause sudden vision loss and pain. Okay, fine. And in this history, you have already ruled out trauma. Then this skin rashes and joint pain and all towards what you want to rule out.
Sir, if we see at this clinical picture, I wanted to rule out if it's due to a varicella zoster etiology. Sometimes patients with an ocular adnexal rash may progress to ocular involvement.
Okay, so this histories you asked after seeing the patient. Okay,
Yes,
yeah.
sir.
So okay, so after seeing had a glimpse at the slit lamp, you ask this history. So skin rashes. Okay, the other one joint pain. Other history. What you want to rule out?
Sir, I felt sometimes HLA-B27 related etiologies can sometimes present as non-necrotizing anti-uveitis, which might mimic such cases. So I
So
just wanted to ask.
non-granulomatous. There is no non-necrotizing. No non-granulomatous uveitis.
Yes, sir.
We want to meet. Okay, so mainly you want to rule out uveitis. Yeah, this
Yes.
Behçet's disease might be no recurrent genital oral or genital ulcers. Then this joint pain also you want to rule out to uveitis. Okay, then no history of trauma. What? Why did you ask the history of trauma or surgery?
Sir, sometimes a patient post any ocular surgery can present with some sort of decomposition, and some patients with endothelial transplants can present as an early sign of graft rejection might also show a similar picture.
Okay, so
When it
we
comes to
can yeah. So one can be a previous after post surgery they can come with correct post corneal surgery edema because there's a corneal edema. So you want to rule out it's a post surgical post surgery edema, or when comes to you because you have like by this time you have diagnosed HSV. So then post any surgery will trigger recurrence of HSV keratitis. So that should be another reason why you should ask of any reasons surgery history because any surgical history or any laser also can cause recurrence of HSV.
okay,
Okay.
sir.
Then what else? No fluctuating vision or loss. You want to rule out uveitis.
Yes,
Okay.
sir.
Okay. So what else you want to ask in the history?
Sir, as I mentioned earlier, my first question was, did this happen in the past? Is it a recurrent thing or a sudden one-time thing?
Then what else you will ask in the history?
Nowadays.
Okay. So, okay, other thing like any reason history of fever. You mentioned fever with rashes because those also can cause recurrence.
Yes,
And
sir.
even lasers also any history of lasers. Then any other medications patients using on. sometimes did you mention or you not mention about the medication, current medication history patient using on? Sometimes patient might be given an anti-glaucoma medication like prostaglandin analogs, which can cause recurrence.
Yes, sir.
So, and there are certain medications, systemic medications, when they take can cause angle, like topiramate and all, or patient takes for migraine, think that can cause an precipitate an angle closure attack. So those any topical or systemic medication patient is using, we have to ask for current
Yes, sir.
medication history. Okay, so okay, now you move to the clinical picture. So this is the picture you have, no? So can you describe this picture?
So this is a slit lamp picture of the anterior segment of the eye. This is I can
Yeah,
I
just tell the picture. Yeah. So when you start describing us, describe from outer to inner. So start with the lid. Okay. So
yes,
though
sir.
in the slit lamp picture, lid image may not be clear, but if you are seeing the patient, so how is the lid? Where are the lid edematous? Then see the lid margin. So lid margin sometimes gives clues in many diseases, even in HSV. It can have a blepharitis, there can be a severe mebomitis. So ulcers, presence of any ulcers, those things to be ruled out. Then see the after from the lid margin, see the puncta. How is the puncta? How is the canthus? Sometimes there'll be a punctal edema that because of the inflammation, and check for Roplas that can be discharged. Those things can be ruled out. Okay. Now go to the now from the conjunctiva to cornea. So conjunctiva, what you see, it's not focused. It's not seen in this conjunctiva. Is not focused that much in this picture. But can you describe?
So there seems to be mild congestion in the conjunctiva that does
Yeah.
not necessarily seem like circumcorneal.
Yeah.
Seems bulbar conjunctiva as much
There's
I
some
can
diffuse
appreciate.
congestion type. It's not very classical of circumcorneal.
Yes,
Okay.
sir.
Then what else you see?
In the
Then after
cornea,
then
sir,
go to cornea. Yeah.
in the cornea, sir, in the slit image, I can see that there is some affliction of the cornea. I can see that there is a disciform lesion in the center of the cornea with I can see some amount of corneal edema, and there also seem to be some keratic precipitates just behind the edema or the area of the involvement.
Okay, so in the slit, first you can say whether the cornea is clear or not. So definitely cornea is not clear. So there is
Yes, sir.
edema in slit. Definitely there is stromal edema, and stromal edema in this slit picture it's not very clear. But you have also mentioned it's very localized. So the disciform means a disc like localized edema. Along with there is definitely presence of keratic precipitates. Though when you describe the keratic precipitates, you should be mentioning whether the characteristics of KPs. So what you see, can you describe the KPs? Actually, not the. It's not very clear in the image, but you can describe how are the KPs. What is the color, size, how it is appearing.
So they appear small in size to me, as we would expect in a case of as compared to a non-granulomatous etiology.
Yeah.
Colors
So
are I'm not
what is
able
the
to discern.
color of the KPs?
So I'm not able to discern the color.
You saw the patient in the slit lamp. Have you seen this patient?
No,
Sir,
he has not seen the patient.
Okay, okay. Okay, fine. So usually, see, fresh KPs will be more whitish, and the margins will not be that much clear, and they are localized, as you mentioned. They'll be localized to the area of edema. So whereas the old KPs, sometimes we can see old KPs also. They'll be more crenated, pigmented. Those points towards old KP. Okay. So you mentioned it correct only. So, but we can see also in this picture there are few white KPs
white
which are
KPs.
which are localized in the edema area. Okay.
Yes, sir.
Then what else you will see? So after the corneas, you will go to the anterior chamber. So anterior chamber may any cells flare that should be seen. Then we'll go for the iris. Sometimes there can be iris atrophy changes or patches of iris atrophy can be noted. Then go for the lens phakic or pseudophakia. Then go for the anterior vitreous space. and intraocular pressure. Okay, so based on this, you have come to a diagnosis of what is the diagnosis?
So my provisional diagnosis is a case of HSV endothelitis.
Okay, endothelial keratitis. So what are the differentials for this clinical picture? What are the differentials?
Sir, viral this picture, sir, after all the negative history, uh, any other viral etiology can also be the differential diagnosis
Correct.
like
So one
CM.
can be, so basically this is a phakic patient, I think. Na phakic patient.
Yes, sir,
So
phakic
there is a
patient, sir.
phakic corneal edema. Okay, there is a corneal edema in a phakic patient. So what are the differentials you think? One is other viral etiology. So it can be you first in this you are mentioning as HSV endothelitis. So the other can be herpes zoster related.
CMV
Okay.
endothelitis.
Okay. Then what else? One is virus related. Then what else?
Sir,
So
if
the
the
other
patient had,
common, sorry.
sir, if the patient had very high rise of IOP, I might have thought of Posner Schlossman because sometimes they also present with localized edema
Okay,
and
yeah, uveitis, correct. Okay, one can be
KPs.
related to uveitis. Then
Um,
other thing can be Fuchs, not uveitis, Fuchs corneal dystrophy. Okay, Fuchs uveitis also, but they don't have that much edema. They generally have a stellate KPs, cataract, iris changes will be there. But Fuchs corneal dystrophy also has presence like a phakic corneal edema. So it's one of the differential for HSV endothelitis. Then what else? What else can have this corneal edema with KPs? Not related to infection, might be.
should I rule in some history of contact with vegetative
Okay,
matter?
yeah, very good. So contact lens, prolonged contact lens wear, hypoxia can cause some edema. Other differential can be any exposure to chemical or toxicity. Those can
Chemical.
also cause an edema. KPs in a dense edema, sometimes we may not be able to see a KP. Okay, but they can also in a phakic patient. So like you can describe this as a differential diagnosis for a phakic corneal edema. Okay, one
Yes,
can be exposure to the toxic chemical or the scalotrophies juice. The
yes,
scalotrophies
sir.
toxicity can also cause. Okay, other thing very rare that's bilateral is alcohol binge can also cause a bilateral phakic corneal edema. Okay, so these differentials to be ruled out. So when you are examining a patient, always you have to examine the other eye of the patient. So what all you will see in the other eye of a patient, rule out. If you are examined, so now you have just mentioned the right eye findings. So left eye in this related to HSV or not, what all you will see in the other eye of a phakic corneal edema patient.
Sir, if it's a bilateral involvement, I would think
No,
more
it's
towards.
not bilateral. Like
Okay.
what all in this patient, left eye, you mentioned everything is normal. But what else you will look for? So what all you should rule out? See, I told you the causes, no? So what related to that? For example, Fuchs corneal dystrophy. So
Yes,
other eye,
sir.
what else? Like that will give us a clue because when a corneal edema is there, we are not able to examine the cornea. So these are clinical judgment will help us to come to a conclusion. So in this, for example, this patient has dense corneal edema. You are not able to see the KPs. So how did you say HSV clinically only? Because you have not
Yes.
done any smear or culture or not based on the PCR. So other eye you should examine and rule out certain things before coming to this conclusion. So other eye, for example, in Fuchs dystrophy, you should see rule out Guttae. So any presence of Guttae points towards Fuchs. It can be sometimes Fuchs and HSV can coexist, but I'm telling you should rule out Guttae in the other eye. Then what
Yes,
else
sir.
you will see for?
Sir, if it's so usually, sir, the dystrophies, as you mentioned, are bilateral. Any
So
kind
other
of
thing pertaining to this case, see HSV can be bilateral and can be recurrent. Okay, so other eye see for a previous old history of any HSV.
scar.
So look for footprint scars. They used in HSV any stromal keratitis can cause scar. Those are called footprint scars. So other eye you have to rule out footprint scars. Any vascularization noted, suggestive of previous infection. Then
Okay, sir.
what else? KPs. So KPs also the old KPs, presence of old KPs in other eye
Crenulated
points
KPs in
towards patient had an episode of uveitis or any HSV keratouveitis and all. So these are an IOP has to be seen, and any iris changes, iris patches or atrophic changes. So these all
sectoral
help
atrophy.
us to come to, because HSV is mostly clinical diagnosis. Okay, so these help us to rule out or rule in the HSV keratitis. Okay. So now you have diagnosed this patient as HSV endothelial keratitis. So how will you classify this disease, HSV? You know of any classification?
Yes, sir. We classify if the HSV infection of the eye can be classified into primary and secondary. What we see
Okay.
in our day-to-day setup is mostly secondary
Secondary,
HSV.
correct. Because primary usually can be asymptomatic or it occurs can present with the subtle symptoms. That is one classification. What else? Can you tell me based on the anatomical location? Do you know any classification?
Yes, sir. When it comes
Correct.
to secondary, sir, it can be epithelial. In
Correct.
stromal, we have non-necrotizing or necrotizing stromal. And it can be endothelitis. In endothelitis, it can be deciform, it can be diffuse, it can be linear,
Linear. Correct. Then
yes, sir.
keratouveitis.
And
Then it goes to
keratitis.
uveitis. Okay. So now epithelial. Can you who, name this classification? You know the from where you have read this classification.
Sir, I don't know the name, but I've read this classification from Cornell Asser book by Namrata Sharma ma'am.
Okay. Yeah. So it's basically it is you can for all HSV related no in AAO by Meckley White and Dr. James Chedosh, a paper is there. Treatment guidelines for HSV. Actually, it's must read for HSV. For PGs also, I feel it's a must read one where everything classification, disease, treatment guidelines are very beautifully given along with head study. So you should go through this American Academy of Ophthalmology treatment guidelines by Meckley White and Dr. James Chedosh. Okay, so it is
Most of them.
all the treatment guidelines are beautifully given. The classification also is beautifully given in them. Okay, so in the epithelial keratitis, how will you classify epithelial?
So if the patient is presenting very early, the patient might just have some punctate lesions along with a dendritic epithelial ulcer. If the
Correct.
patient is presenting late, we might see some dendritic ulcers, and some of them are coalescing to form a geographic and
Correct.
amoeboid
So
type ulcer.
HSV starts as the virus infection starts as a corneal vesicle. Later they unite to form a dendritic ulcer. Okay. So why they take the shape of dendritic ulcer?
They start by swelling the epithelial cells, and once the other epithelial start to get involved, they presume the shape of a dendritic ulcer, and they usually have terminal bulbs where the activity of those cells is the most. Activity of the viral antigen is the most.
Most. And can you like any special stain available to see them clearly, to delineate them clearly?
Sir, if we use fluorescent stain, we can stain the ulcer base properly, and for if we use rose bengal, then we can stain the bulb properly. They
This
usually
rose
stain
bengal
the
usually stain the viral laden cells which are in the margins. That is the
yes,
double
sir.
stain. So you can use the double stain. So you told me about double stain. So you know a condition where reverse double stain is seen.
So a reverse double stain or reverse staining, sir?
Reverse doubles, like you told me what is double stain. Okay, where the fluorescent stain in the base and the rose bengal stain in the margin. So where the reverse double stain is seen, you have any idea?
Sir, I think epithelial basement membrane dystrophy reverse staining is seen. I don't know about reverse double
It's
staining.
usually seen in neurotrophic ulcers.
Okay,
Okay,
sir.
even when HSV metaherpetic or neurotrophic ulcers, this reverse double stain is seen. Okay, so and if you are planning to other Perlis, if you are planning to do any PCR to send for the virus diagnosis, HSV PCR, you should do before rose bengal staining because rose bengal stain is toxic to the virus. Okay, so
Yes,
the
sir.
positivity of the PCR will not be there when you do it after rose bengal stain. Okay, so if you are planning to send for PCR, you should not do rose bengal stain. Okay,
Yes, sir.
do it after you scrape and send for the PCR, viral PCR. Then, so then dendritic you have told me, geographic you told me. Then what? How will you treat dendritic and geographic ulcers?
Sir, I would start a topical antiviral such as acyclovir 3% ointment, which is to be given 5 times for the initial 7 days. And if I'm seeing that the patient is responding well, then I would like to decrease the frequency of acyclovir and not continue it more than 14 days because it can be toxic to the cornea itself.
But minimum period of 14 to 21 days, topical
Yes, sir.
antiviral should be given. Why? Why not 1 week, 5 days, like we give in other bacterial ulcers, or like conjunctivitis, we give 1 week, once it resolves, we stop. But here we recommend minimum for a period of 2 to 3 weeks. What is the reason?
Sir, I think it has to do with the viral replication, and we have to suppress it completely, or there might be
Viral
recurrence.
replication as well as the epithelial shedding. Okay,
Yes.
so for the epithelium from the basement towards the surface for shedding, it takes 14 to 21 days. So based on it, we suggest to give topical acyclovir for at least 2 to 3 weeks.
Okay, sir.
Okay, what else? Acyclovir, or what else you can give topical?
Sir, a topical lubricating drop as well to promote the
So there is
corneal
other
healing.
ganciclovir 0.15% also can be
Yeah,
given.
yeah.
Do you need antibiotic also?
Most probably no, sir.
Not needed. So only topical antiviral along with the patient has severe pain, cycloplegic.
Yeah.
Okay. Okay. Now after epithelial we'll go to stromal keratitis. So what are the two types of stromal keratitis? You already mentioned. One is with ulceration, one without ulceration. Okay. So what is the difference between the both?
Sir, oral necrotizing is a very fulminant kind of an etiology, while non-necrotizing immune stromal keratitis will limit itself to just the stroma.
Correct. So as the name says, immune stromal keratitis, more of immune reaction to the virus. So it's immune mediated, whereas a necrotizing, it's more where there is a virus active infection is present along with an immune mediated. So that is necrotizing stromal keratitis. So clinically, how will you differentiate both? Like, can you tell me, like, if you see this is a characteristic of immune stromal, and this is characteristic of necrotizing. So how will you clinically tell me that's immune stromal or necrotizing?
Sir, when it comes to stromal, which is the interstitial in nature, the eye, other than the cornea, will mostly be quiet. We can see immunering of Wesley's,
Correct.
which is also associated with it. In necrotizing cases, other components like iritis and trabeculitis are very much involved.
Okay, so
Uh,
basically it's immune mediator. So there is mostly it's an immune reaction to the virus. So there is stromal edema cellularity. Where there is no epithelial defect, there is no epithelial involvement, and the eye will be absolutely quiet. Patient might be complaining only of blurred vision. When there is an HSV immune stromal, patient may not even complain of redness or pain. Whereas necrotizing stromal keratitis, patient will be more symptomatic also. Patient will be there will be an ulceration, stromal ulceration, along with the presence of stromal infiltrate. Okay, uncellularity will be there. So how will you manage? So what medications you will give for immune stromal keratitis, and what you will give for necrotizing stromal?
Sir, for immune stromal keratitis, it requires topical antiviral in form of acyclovir, 3%, and it's an ointment around 5 times a day. But stromal keratitis also requires a topical steroid in the form of prednisolone acetate, 1%, which we can start around 6 times per day. And then,
So, correct, as you mentioned, the stromal, we have to give topical steroids along with an acyclovir. But topical steroids is of utmost importance for a immune stromal keratitis. Okay, so now we'll before going to that stromal keratitis, with regards to oral and topical antiviral, so for epithelial, which is preferable?
sir, for epithelial, only topical is required.
Not necessarily. So in epithelial, both topical and oral can be given. Okay.
Okay, sir.
But generally we give topical because we think the concentration of the topical will be better than the oral. But for like there are studies which have shown that the concentration of acyclovir that reaches aqueous is almost same for both oral and topical. So both can be given. But since
Okay,
for a
sir.
short course we start with topical. Okay. So, and when it comes to stromal, also we can give both topical and stromal. But when come from stromal keratitis and all, oral is preferable over topical. One reason might be the duration, because for a stromal keratitis, the topical steroids, according to the treatment guidelines, minimum of period of 10 weeks. Topical steroids should be given at least for a duration of 10 weeks. Okay, so we cannot give a topical acyclovir for a duration of 10 weeks or so because of toxicity. So we can consider oral, and moreover, the stromal concentration of the acyclovir, what they have told, oral is better than topical when it comes to stromal keratitis. Okay, so for treatment for immune stromal keratitis will be topical steroids in tapering dose. You can start from 8 or 6 times over a period of 2 weeks. Slowly taper over a period of 2 weeks, along with an oral acyclovir. You can give around, there are oral acyclovir also as either therapeutic, any antiviral, like this one, acyclovir, valacyclovir, famciclovir. It has a therapeutic dose as well as prophylactic dose. To refer, I'll tell you to go through the treatment guidelines of AAO, which has beautifully they have given what are the therapeutic and prophylactic dose. But to this case, I will mention might be for a stromal keratitis. You can start with for immune stromal. You can give the prophylactic dose 400 mg twice daily, along with topical steroids. Okay, topical steroids you can start 8 times for 2 weeks, then slowly taper.
Sir, when it comes to
we'll go on to necrotizing stromal. So necrotizing stromal will have an infiltrate. There is a stromal ulceration along with the stromal cellularity. So whenever there is an epithelial defect, so topical steroids, we should be very cautious in starting topical steroids, because topical steroids is a double-edged sword. That too when an active epithelial defect on ulceration is present, because there is an always chance of melting when in the case of active ulceration. So always rule out a secondary infection. So necrotizing stromal as an infiltrate. So clinically you have seen the patient, you are seeing there's a stromal infiltrate, and clinically you say it's HSV necrotizing, but there can be a coexisting bacterial or fungal infection or any parasite infection. So always do corneal scraping, rule out the other co-infection, then start on oral acyclovir for a period of week or so, then start on topical steroids. Okay, once you start seeing the response. And when it comes to necrotizing, its name itself says it's very aggressive also. So there is always a chance of perforation. So always watch for thinning and do glue, either glue BCL or amniotic membrane, whatever needed as in the course of the disease. Okay, so we should be very watchful about perforation in case of necrotizing stromal. And for necrotizing stromal, we'll start with the therapeutic dose oral acyclovir. For acyclovir and saline, it will be 400 or 800 mg 5 times a day. Then shift to, for a period of 2 weeks, then shift to a prophylactic dose 400 mg twice daily. Okay. So this is for necrotizing stromal. Now we'll move on to endothelitis, the actual case. So how will you treat?
Sir, I just had a doubt.
Yeah.
Sir, when it comes to non-necrotizing, can we directly start with the prophylactic dose, or should we give
we can start on prophylactic dose? See, the idea being giving prophylaxis doses when we put the patient on topical steroids, there is a local immunosuppression is created and the virus activity can occur. Though we say immune mediated, there is a local immunosuppression when you give topical steroids, and there is always a chance for the virus to get reactivated. So to prevent that, we give this prophylactic dose. So for immune stromal, you can start with 400 mg twice daily along with topical steroids.
Okay, sir.
But for necrotizing stromal, definitely therapeutic dose is needed. Okay, so for now, how will you treat this your patient endothelitis?
Sir, I think treatment here or and topical
Here
steroids,
you can start with
the frequency of topical steroid,
then shift to prophylactic dose after a period of 10 days to 2 weeks. Then topical steroids, you can start from 8 times and then in a 2-weekly taper for a period of at least 10 weeks. It has to be given. Okay, and you have mentioned the IOP is also high. So anti-glaucoma medication to control IOP also should be started. And sometimes this endothelitis, keratouveitis also can coexist. It's very difficult to say, because with the corneal edema, when you're not able to see the cells flare and the intraocular pressure is high, so there can be a coexisting keratouveitis also. So you have to check intraocular pressure, and anti-glaucoma medication has to be added. Okay.
Yes, sir.
So this is about roughly about the treatment. As I mentioned, you go through treatment lines in clearly. Okay. So then when you give acyclovir, what systemically you have to monitor?
Sir, at the very basic, liver function tests have to be monitored.
Mainly renal function
Yes, sir.
test, okay, because they're nephrotoxic. So renal function test has to be seen. And actually, oral acyclovir is very safer drug, even for elderly people. Acyclovir is a very safer medication, so can be given, but renal function test has to be monitored.
Yes, sir.
Okay. So when you will repeat the renal function test, might be after every 3 to 6 months.
Okay, sir.
Okay, you have to, when a patient is on acyclovir, you have to check the renal function test. Then, so have you heard about acyclovir prophylaxis for HSV keratitis?
Yes, sir. It requires a 400 milligram BD for a very long term, like 1 year or even
6 months
more
to
than
1
that.
year. So what are the indications to give prophylactic acyclovir?
Sir, if a patient is coming with a recurrent history of stromal keratitis,
Correct. So for any recurrent epithelial, do you give acyclovir? Ideally not needed. For recurrent
yeah,
epithelial, it's not needed. But patient with a recurrence is 2 to 3 episodes of a stromal keratitis, you have to give oral prophylactic dose. Then a stromal keratitis with ulceration for a necrotizing stromal, because it has a very severe course of action. So patient who had a necrotizing stromal keratitis, better to start on oral acyclovir prophylactic dose. Then like see the risk factors, and a patient who are planning to have any surgery, patient with planning for surgery, we should give a prophylactic dose, like planning cataract surgery for a patient who had HSV keratitis, or planning for a laser, even YAG laser, YAG cap have cause recurrence. So for these patients, or you are planning a keratoplasty, so those patients also you have to start prophylaxis. And patients with for cataract and other smaller procedures, still they are in the topical steroids, you can give the prophylaxis. But with respect to penetrating keratoplasty, the prophylaxis is given for a longer duration, till the patient, better to give till the patient is on topical steroids. Okay,
okay,
when
sir.
the patient is on topical steroids, you can give a prophylaxis of oral acyclovir. Okay, so there are other medications also available. Val acyclovir also is given as prophylactic dose, or famciclovir. Okay.
Yes, sir.
Then you have read about HED study, at least like the say HED study is there is HEDS1, HEDS2 study in multiple phases. It's there. So can you just tell me the key salient points of the HED study?
Sir,
So I have given you, we have given a patient the acyclovir prophylaxis. Can the patient get recurrence? A patient who is on acyclovir prophylaxis, can they get recurrent HSV infection?
sir, according to HEDS trial, they can, but it's a less probability.
Correct. So they can, but there is always a 40 to 50% chance of less severity, and there is almost 40% reduction. What to say? Less chance of getting the recurrence. They can still get, but there is always 40% less chance of getting.
Yes, sir. So HEDS trial, I think it answered 5 to 6 questions, like two topical steroid treat stromal keratitis.
Correct.
Is oral acyclovir required in treating stromal keratitis?
Correct.
Is oral acyclovir required in HSV iridocyclitis?
Correct.
Can it prevent recurrences? And what are the triggering factors by which a recurrence can come back? I
Correct.
think it answered mostly these questions.
Correct. So any vaccine available for HSV?
I'm unaware of.
Actually, it's available, and the HED study also, not in the HED study, in the AO treatment guidelines also, they have mentioned that taking vaccine, people who have got vaccine, they have a less chance of getting viral recurrence than people who didn't get the vaccine.
Okay.
Okay. Okay, so this is roughly about the treatment and overall clinical picture of viral keratitis. Any other questions here? Or any other participants, any other questions?
Sir, how pertinent is it to rule out any other viral cause like CMV endothelitis?
Yeah, we should always rule out because we are treating this patient based on clinical diagnosis. Okay, so if you want to confirm, we do either PCR, cell culture, we have to do, or IFA, immunofluorescence assay, like the antigen. So, PCR can always able to do the real-time PCR than the normal PCR, and to see the number of viral copies, to detect the number of viral copies, as well as when you combine two tests like PCR with IFA, the sensitivity and specificity of the test is better when compared to just doing PCR. Okay, so it's basic, and those reports take time. So we treat this patient basically based on the clinical signs and symptoms. So it's always we should rule out CME endothelitis, HEZ2 endothelitis. If you by clinically also, for example, CME endothelitis have a very large KPs, raised IOPs, the coin-shaped KPs. Those things points towards clinically also towards CME endothelitis. If you have any doubt, you can always do AC tap and send PCR for all the viruses,
Okay,
varicella
sir.
zoster, CME also. Okay, it's better because it's a basically it's based on clinical diagnosis. So your clinical acumen will help us to initially start the treatment. You have to monitor the progression of the disease and take a call.
Yes, sir.
I think that is very important point which you mentioned, that this is a clinical diagnosis. So yes, PCR is available, but the cost and the time is a factor. And the other thing is that this disease is not a fulminant disease. If you're talking about just stromal keratitis or even endothelitis. So even if you are treating CMV endothelitis with acyclovir, so as Dr. Mukandan said, it is the clinical response. So if there is no response, then definitely you have to think about that your diagnosis is wrong or your treatment is wrong. With the HSV, you have to remember that that treatment is not that it has to be an urgent. It is not like if you don't treat it on the day you have seen that you will lose the eye or anything. Even with epithelial keratitis,
Correct.
you can take your time
And
and
HSV is epithelial is self-limiting. So even
yes.
if you don't do anything, it can cure in 2 weeks.
Yeah. So what is very important is what not to do. So
Okay.
what not to do is not to start steroids in a case of epithelial keratitis. And in this case, as Dr. Mukandan has already explained, that starting on antiviral when you are starting on steroids, because that is going to prevent the spread to the epithelial recurrence. And and the dose, because that dosing is, there is no fixed whether you should go for 5 times, especially I missed the point, Dr. Mugandan. In case of endothelitis, do you like to keep it 5 times or just a prophylactic dose? Because there are different.
I like to keep 5 times. Only in stromal I give prophylactic dose, rest all, because always there is overlap of endothelitis, keratoivitis. So I always give 5 times and then only shift to after 10 days. Though they say 2 weeks, sometimes for 10 days, then we can shift to prophylactic dose.
So that is a very important point, that it at least 400 milligram, because at times people give 200 milligram and it is not a prophylactic dose, it is not a therapeutic dose.
And
And
acyclovir is a very safer medication. Like there are people using for a year, 2 year also. It's a very safer unless they are like people with renal impairment. And there is also renal clearance available. So you can check that and then reduce that acyclovir dose for even people with renal impairment.
I think second point, very important, like you said, is cases of stromal and endothelial, that starting on topical antiviral is not a practical solution. Because if you continue, then you will have the epithelial toxicity.
Toxicity.
Then your diagnosis again will go whether now it is an epithelial recurrence or, so it is always better to start with oral this antiviral when you're treating these stromal and endothelial components. Dr. Mugandan, what is your view on ganciclovir versus acyclovir in cases of HSV?
Actually, acyclovir is cheaper. I feel that is the main reason we all start giving from fellowship days in LV
Right.
Prasad, irrespective of paying, non-paying, we give acyclovir. So that it automatically comes, and acyclovir is cheaper, much cheaper compared to other medications. Even oral medicines, when it comes, oral acyclovir strip is much cheaper than val acyclovir strip. So that is the reason we tend to give acyclovir. But people feel affordable and want to give less dosage. For example, val acyclovir, people therapeutic dose of acyclovir is 400 mg 5 times. Val acyclovir 1 gram 2 or 3 times can be given for a therapeutic, and prophylactic can be just 500 mg once daily. So affordable patients, we can consider other medications also. But since it's acyclovir is cheaper, it's been prescribed more commonly.
In the topical versus ganciclovir.
Ganciclovir also, yeah, Vison gel is available as a ganciclovir. It also is the same only for acyclovir, and topical acivir and Vison gel both work same only.
Yeah, because some people find that it is a gel form, so maybe little less toxic and the dosage is little less for. So you are using 3 times or 5 times for.
I used to give 5 times only initially for first 1 week. Maybe if we see any sign of toxicity, then reduce it to 3 times.
Anyone else having any doubts, any questions? On because viral keratitis is
It's very common.
But it is still tricky because
tricky to treat.
Yeah. And
Sir,
especially
I had a doubt.
yeah, please go ahead.
Sir, in one of my peripheral centers, I am used to see a patient who comes with recurrences of stromal keratitis. I had explained it to him that one recurrence increases the chance of the other recurrence. He said in the past 7 to 10 years, he has been on and off of tablet acyclovir. My question was, how long can we continue prescribing the prophylactic dose to such patients?
See, as I told, acyclovir is a very safer drug, and if he's systemically good, and see, recurrence means the indication to start is in a year, 2 to 3 episodes should be there, on and off. Like once in 2 years, one episode is not like it's also recurrence, but it's not an indication for prophylaxis. In a
Okay, sir.
year, he is getting 2 to 3 recurrence of stromal in a year, or any one stromal necrotizing stromal keratitis also, or in one eye he has developed an ulcer that has caused scar involving visual axis. So we don't want to get him in the other eye also, a scar in the visual axis. So those cases you can put him on a long-term prophylaxis. Then after a year or so, we can give a prophylaxis free period and see when he gets the recurrence. If he's not getting, then we can give a free period, prophylaxis free period for 6 months or so. If he's not getting any recurrence, we can observe. Or if he's getting recurrence, we can again restart.
Sir, if the patient has now developed bilateral scars and most of them are in his visual axis, is it still good to start the prophylaxis? Or
But when did he last get the active episode? For example, bilateral scar, but last 5 years he didn't get any episode, then no need. But if he's getting recurrent, like in this year, he is getting second or third, then definitely we have to put him on a prophylaxis.
Sir, sometimes I have some difficulty discerning which is the area of activity and which is like
Slit
already
lamp,
done.
because it is always in the stromal, because with ulceration and endothelitis the KPs, it's very easy to identify. The stromal always it's clinic, we have to make a slit lamp, and scar will be, there'll be flattening, activity edema, there'll be a like bulge will be there in the main is slit
Yes, sir.
lamp.
Yeah,
If you have a option of anterior segment OCT, you can do, but I feel
okay, sir.
always clinically,
Yeah.
if you see a scar will have a flattening, activity will have an edema and cellularity where there will be a bulge. So slit lamp only by slit view.
So one day I took the photo and then only I realized this is the activity and this is not, because sometimes,
Through
yeah,
slit only is the
yeah,
main thing.
yes, sir. Thank you so much, sir.
Yeah.
I think that
Good
is
job,
a
Rohit.
very important point what Dr. Mukandan
Thank you,
said,
sir.
that repeated occurrence of HSV is a natural history. Any patient who has got HSV once can have a repeated occurrence. That is not the indication of starting a acyclovir prophylactic dose. I think that is very important point which you also brought and Dr. Mukandan has explained, because every patient, if he has a second episode, that is not an indication, because the natural history of HSV is such that the patient can have repeated episode in his course of life. Okay, so when the incidence, when the occurrence is happening too many times, then only you should think of starting a prophylaxis. Just a second episode of HSV is not a indication
Indication.
for prophylaxis. Because if once someone is on prophylaxis, then it is difficult for someone else also.
To when to stop.
Yeah.
Correct. So when you see the patient with prophylaxis for 6 months, then it's always we don't know when to stop. Correct.
And the other thing for stromal keratitis, and this is that the steroids have to be a pretty long period. You should not taper in a month.
Like cataract, correct. Exactly. So AO guidelines is a minimum period of 10 weeks.
So 10 weeks means we are talking about 3 months.
Correct.
Roughly 2.5 to 3 months. So because you will see the response and you will be in a hurry to taper, but that is the, and we don't know, sometimes it can be longer also. So
Correct.
that is one more thing which is very important takeaway, that these steroids have to be slow and over a period of a long period. They have to be very this, not even like an anterior uveitis. It has to be a very slow and a long period, like minimum 2.5 to 3 months tapering of topical steroids.
And when respect to necrotizing, when you see a necrotizing stromal keratitis, don't be in a hurry to start steroids. And if you have a very good associate with any cornea clinic, please refer to the patient, because necrotizing stromal with super added infection can melt so faster. Like you will not even expect within a week a patient can end up in total melt. So if you are in your place, if you are able to treat a patient necrotizing stromal keratitis, it's okay. But if you feel there is a worsening and you start on medications, and that to be very cautious with topical steroids. Okay, because necrotizing stromal, we should be little vigilant also in starting topical steroids, and follow up also we should be very careful.
Yes, sir.
Anyone has any doubts with Dr. Mugandan? Because he's here, and if anyone has any questions. So I'll have this between a stromal and an endothelial. How much is overlap, or you would say it is important to actually diagnose whether it's like if you have diagnosed endothelial keratitis as a stromal or vice versa.
I think it will not make much difference, because the treatment for stromal endothelial almost the same. Might be endothelitis will treat little aggressive.
Right.
Might be so, but it will not, even if we misdiagnose endothelitis as a stromal, it will not affect much, because that course overall we give the almost same medications and they respond well.
I think if we have no more doubts, we'll end the session. And that was a really nice presentation from Rohit. I think it was really courageous for him to come on this platform and present in front of everyone. And Dr. Mugandan for taking his time out from his busy schedule and helping all of us with this tricky topic. I think we have one question. Shraddha, you can take the mic. Dr. Shraddha?
Hello. Yes, sir. Good evening, sir.
Yeah, please go ahead.
Sir, I wanted to know the role of oral steroids in management of stromal
Stromal.
keratitis,
Actually,
apart from topical steroids.
Okay, so oral steroids are not commonly prescribed. So, but there are
Okay.
cases where we have prescribed oral steroids, might be when you are in a situation not able to start topical steroids. Might be oral steroids I feel have a less role in case of immune stromal, might be in in a necrotizing keratitis with stromal ulceration, where you are little cautious in starting topical steroids or in a low dose steroid. Might be in those cases you can start oral steroids. Or in a case of keratouveitis where there's severe inflammation, you can consider oral steroids.
Okay, sir. Okay, thank you.
Not very commonly used, but it has its use in case of might be non-necrotizing where you cannot in a necrotizing stromal where you cannot give high frequency topical steroids. You can put them on oral steroids along with low dose topical steroids to start with.
Okay, sir.
And in case of
Thank you,
severe
sir.
uveitis, when there is an keratouveitis with significant inflammation, we can start oral steroids.
Okay, sir. Thank you so much.
A very interesting question.
Thank you, sir.
And Rohit, also you did a good job. Like you
Thank,
almost answered most of the questions.
thank you so much, sir.
Yeah,
Okay.
all the best.
Call it a day.
Thank you, sir.
And thanks everyone. Thanks for joining.
Thank you, sir. Thank you, Dr. Anuj, for giving this opportunity.
Have a good night, everyone.
Yeah.